Hi, I'm Ann Berg. I'm an epidemiologist and clinical outcomes researcher. I'm at Northwestern for my academic affiliation, and my heart and mind are with Families SCN2A Foundation, Deep Connections, and the Decoding Epilepsies, Developmental Epilepsies, and of course the Inchstone Project. We're going to talk a bit about communication and behavior today. You've already heard quite a bit. The 21st Century Cures Act requires that patient experience data be incorporated into the development, evaluation, and use of therapies. PED, patient experience data, can be collected from almost anyone who has experience with the disease, patients, caregivers, physicians, and others. And the types of databases and sources of information are highly varied. They can be really organized patient registries, they can be focus groups, and usually we use multiple sources. PED is intended to provide information about patients' experiences with conditions or the disease, and this includes the impact on the individual at many different levels, as well as patient preferences with respect to the treatment of the disease or condition. The goal ultimately is to identify what's most important to patients and caregivers. Those are things, items, issues about the disease that are life-altering and life-limiting, and to make sure that treatments, when they're assessed, are assessed with respect to these outcomes to see if they actually improve what is important to patients. So what is Lennox-Gastaut syndrome? Well, we know by definition it includes seizures, right? We've heard a lot about that. A long time ago, I learned from Tracy that Lennox-Gastaut syndrome was the founding member of the Really Crappy Seizure Club, and it remains so still today. But as we read the definitions in the literature, and apparently the recent ILAE one as well, we see reference to severe, moderate to severe to profound developmental and intellectual and cognitive disabilities. If these are important and we want to address these through therapy, we need to be able to measure them. So the common approach is to go to the online clinical outcomes assessment boutique, COA, and pick something that looks good and use it. That's what we've seen everyone do. So, and there are a whole bunch of really fantastic measures out there. There's the Vineland. How many parents in this room have filled out the Vineland on their child? Raise your hand. Keep your hand up if you think it was a really good measure for your child. Yeah, that's what I thought. But there are other measures. There's the Bailey, the ADOS, the Brief, a whole host of measures, and they're really good. They've been very well designed and validated, and when they're used properly, they're excellent measures. What we have to do, though, in a new disease that has not been well characterized is to understand exactly what needs to be measured in the group under study, then ask, what is this instrument actually measuring? What was the original purpose of the instrument, and whom was it intended for use? And ultimately, is it really appropriate for the setting in which we want to use it? The FDA followed up with the patient-focused drug development guidances, and you've already heard from Scott Andrews a bit about this, and Michelle, I hope I get this right. You can tell me afterwards, but there are 4 guidances. And these are intended to help drug development in choosing good clinical outcome assessments. The first 2 guidances are really focused on research design and methods and address where do you go, whom do you ask to get this information, how do you collect this information from people, and then how do you elicit the information that you need, how do you ask the questions. The other 2 guidances, the next 2 guidances are available in draft form. G3 focuses in on what makes a good clinical outcome assessment measure, and that's what I will focus on. And the G4 focuses on a really essential thing, and that is once you have that measure, how do you turn it into an endpoint to be used in the trial, the thing you're actually going to measure and analyze statistically. It's not the same thing. The third guidance focuses in on which instruments to use and why, and ultimately addresses the concept of fit for purpose or fitness. FFP encompasses the concerns and criteria for the content of the instrument, and we'll talk a bit about that, mostly about that, a whole host of psychometric concerns, and Jenny Downs mentioned some of those already. And then also some practical issues. How is this instrument practically applied in the situation in which you wish to use it? And we're not going to talk about that so much today. But the first thing we have to ask about is, what is it we're going to measure? What is the concept that we've learned about by following the first two guidances? And the concept of interest is that aspect of the individual's clinical, biological, physical, functional, et cetera, state that you wish to capture and reflect, and hopefully through treatment ultimately improve. And it can be a whole host of things. It can be seizures, gross motor function, gait dynamics, alertness, engagement with others. We've heard about communication, very, very critical, but pain, sleep, and so forth, and disruptive behaviors. This is the roadmap presented in the third guidance, and it starts with the first two, basically what we do in the first two guidances, find out from people who know what's important, identify what's important, and then we go through the process of selecting the clinical outcomes assessment and studying it, and ultimately we hope to have a fit-for-purpose COA. Now, the FDA identifies 3 ways of doing this: using an existing COA, off the shelf, developing a whole new one, and you've already heard from Jenny Downs, that is a lot of work. That can take years to do, and it's millions of dollars to do. And it's sort of like Goldilocks, the intermediate one that's maybe just right and is certainly recommended in the guidances, the rare disease guidances, and also the current guidance theory series, and that is to take something that already exists that's in the right direction and then to work with it to modify and adapt it. Now, I want to point out why off-the-shelf COAs are not a good idea. I think you've already heard a little bit about this, and you've also seen some of these slides. These are data from the Simon Searchlight SCN2A cohort using the Vineland-2. And what you see here are the standardized scores. The scores are standardized to a mean of 100, standard deviation of 15. And they're standardized by age. So you'd expect the average 10-year-old should get this score, the average 12-year-old this score, and so on and so forth. And what you see is that these scores decline over time, over age, admittedly cross-sectionally, but we've demonstrated this longitudinally as well, as have others. And you can see that for the overall composite score and for all of the components that go into that score. Based on this, we don't know, are children regressing? Are they starting off with skills and losing them? Or is the population going like this and the children with DEEs are going like this and they're plateauing? Or are the populations going like this and the children with DEEs are moving, but just not that fast? So they're really falling behind same age peers. Let's focus in on this. I'm sorry I don't have a pointer, but here's just the communication score. And in green, you can see the norm referenced mean of 100. One child in this cohort had an average score. Over half were more than 3 standard deviations below the norm referenced mean. All right, that's a lot. In fact, we would only expect about 1 in 1,500 people in the population to score that low. Now, here's the rub. These instruments were designed not to study the 1 in 1,500. They were designed to study the 1,450 in 1,500, okay? The bulk of the population. We think we're studying communication, but what is that concept in someone who is so impaired? That gets us into the idea of a conceptual model for our concept of interest. If we think about communication in the Vineland and in many other instruments, we usually break communication into receptive, expressive, and written. Now, what you see here in these smaller, on the right of the slide, are not the standardized scores, but just the raw scores. Okay, it's not how someone did relative to someone else the same age, it's just how many points the person got on the test. Not if it's an A or a B, just how many points. And what you can see is that the receptive communication, and I think, Jackie, you mentioned this about your son, Devin, that he had pretty good receptive communication. It was there. And in fact, what we see is that there is a fair amount, at least according to this measure in the SCN2A group. Expression, not so much. And you can see that there's some movement in there, but everyone's kind of squashed down near the bottom, and it's really hard to see what's going on. And then when we get to written, it's like, there's just not much there. Yet our communication score is a gemisch of all of these. So we have to rethink our conceptual model for the concept of interest, because people with profound intellectual and multiple disabilities, and this is a term I want to put out there once, and then my colleagues Natasha Ludwig and Mary Wojanowski will talk about it further. Communication in this group's not the same as with neurotypical individuals, and we have to flesh out what is it. There's a lot of verbal, but there's a huge amount of nonverbal communication. There's for both receptive and expressive. You heard about the use of communication devices from, I think again, it was Jackie or Crystal. The purposes for which someone communicates. You heard about not knowing about basic pain. I mean, that may be what we're communicating about, and a whole host of other factors. How do we incorporate ACCs into our assessment? A lot of children use them, but the language is different. One common question on various assessments is, does your child use pronouns properly? Well, on a lot of these devices, there's a single pronoun for I, me, mine, to me, from me. All the declensions go down to one symbol. What do you mean by proper use of pronouns? Okay, you really have to think about that. We have to reimagine communication. The other issue too is, well, there are many forms of AACs. You can't just say on an AAC. You have to know the specific one. You heard about the first one, and then the TOBY. I mean, they're very different. And also vision and motor impairments may affect how we communicate. I want to touch briefly on behavior. You heard a lot about some pretty serious behavioral problems from Andy and Crystal. But in general, and actually the issues they discussed are at another end of the spectrum from those that I'm going to discuss, but in general, people with severe DEEs actually have very limited behavioral repertoires. And problem behavior checklists and instruments often ask questions like, is your child verbally aggressive to other children? Does your child talk to himself loudly or deliberately ignore directions? And I can't tell you how many parents would say, I wish my child could deliberately ignore my directions. That would at least mean he understood or she understood what I was saying, but that's not the case. I work a lot with the SCN2A community. There's a lot of choreoathetosis in that group. What does meaningless recurring body movements mean? We really have to get very specific about what we're asking and how we ask it if we want to have a good instrument. This is feedback on a disruptive behavioral measure that we used in the SCN2A CTRS study. We asked the parents to tell us what they thought, and I think this will resonate with a lot of you. Defining a temper tantrum was hard for me, as my child's behavior is how he communicates. That's how I know he's hurting. One of the parents, I think Trisha, you talked about, was it Trisha who talked about the toothpick? No, yes, right. Another parent said, I don't like the term temper tantrum. I know what you mean. But, you know, it's really more like my child's having a meltdown. They're overwhelmed. Their nervous system is out of whack. Is that an aberrant behavior? Is that a disruptive behavior, or is that something else? Our daughter doesn't show she's upset by acting out. She shuts down. It's a whole different response. And a couple parents, in response to asking about transitioning, said, my child is so cognitively impaired, he's not aware that we're transitioning. So when you say no, there's no problem, does that mean your child's well behaved? Who knows? I mean, it's not a very helpful kind of question. So we have to reimagine this. The FDA gives us this very nice roadmap. That middle part, though, is not linear. It's actually part of a very recursive, iterative process where we start with some questions, we develop or use instruments, we go to the community, try it out, sit down, work on it, fix what's not working, and do it again, and maybe again and again a few times. Ultimately, measuring communication, behavior, or anything in the presence of PMID requires deep knowledge of the condition. It must be driven by the caregiver and patient priorities, and we really have to understand the concept of interest as it is expressed in that population. The Inchstone project, which you've heard about a lot, thank you everyone for mentioning it. Our goal is to develop one or more COAs that would be suitable for use in populations characterized by PIMD, and LGS is certainly one of those populations. We're trying to understand what children can do, not show that they can't do everything else. We want to know what children can do and can build on, and children and adults, I should say. If you're interested, parents, physicians, if you think you have patients who might be interested, please scan this QR code. It will be shown again by my colleagues, and your access code would be CAPE. That will take you to our screening page, and you can see if this is a good fit for you. If you have any questions, if you missed this, ask me, ask Tracy, we'll get you in touch. One thing I would ask, though, is please do not post this online. We did get hacked, and people put in garbage data using something like ChatGTP, and it's not your voices. We just want your voices. If you need help getting in touch, come directly to us, okay? With that, I thank you very much, and I'll pass this on to my colleagues. Yes? Okay, thanks.